Thank you, Mike. And I'd just like to thank IAS-USA for organizing this. I think this is a fun opportunity to talk about the recommendations. Hopefully, people can see the slides. So just wanted to welcome everyone. I know there have been a lot of questions even before the chance to have this course to talk about some of the new prevention recommendations. I think some of the topics that people were surprised or particularly interested in were some of the recommendations about what PrEP regimens to preferentially use. In particular, the elevation for the first time of the recommendation of injectable PrEP, should it get regulatory approvals and have availability. So that'll be good for us to talk about. We'll also talk more about TAF-FTC and its use as a prevention agent. We'll talk a lot about the elevation of 211 or on-demand PrEP to a first line recommendation with equal footing with daily oral TDF-FTC for MSM. We'll talk about some changes in our recommendation to testing and monitoring intervals, some issues around persistence and retention, around recommendations for adherence and persistence support, which I think are particularly challenging with oral PrEP preparations for certain. A little bit of insight in transgender pharmacokinetics for PrEP agents. And we specifically enunciated some recommendations for trans feminine individuals, and we've gotten some questions and, of course, a lot of interest about trans masculine individuals. So wanted to make sure we had some time to talk about that. And then, if somebody acquires HIV despite being prescribed PrEP, what one does in terms of choosing an initial ART regimen, and whether there are insights that can be gleaned from the amassing data from TDF and TAF FTC PrEP. So those are the sort of the topics that we're going to sort of be going through today. I wanted to sort of begin and sort of kick off the discussion by actually opening up a poll question to our audience as a Kickstarter to this conversation. Hopefully I can get the slides to advance to our poll question. This is our first poll question to kick us off. I hope people are okay with being interactive here. And what do you prescribe for your first line agent for PrEP? And some might take issue with the fact that we don't specify a population here. So just for sake of argument, let's say it's for MSM, just to kick off the discussion. So hopefully people have an audience response question that popped up on their screen, and people can vote. And then when the number of responses go down a little bit, Stephanie can share with us the results. Okay, so just over about half of people said TDF FTC, either on demand or daily. 15% of you said I don't prescribe PrEP, and 29% said they would essentially immediately go to TAF FTC, and no one said something else. So Jean-Michel, I'm curious, what are you doing in Paris right now for first line PrEP?
Well, hello everyone. Yes, so we use mostly PrEP for MSM and transgender individuals today. Very few heterosexual actually are on PrEP in France. TAF-FTC is not approved for PrEP at this time, so we only use TDF-FTC, and we actually are fortunate enough to have generic drugs. So the cost of generic TDF-FTC is very attractive. I used to say it's even cheaper than condoms today in Paris, because the 1 month of daily TDF-FTC, if you get the drug at the hospital pharmacy, is only worth of 10 euros. So probably less than $10. And, in terms of daily or on demand for MSM, we are split, and it's 50-50. So it's upon, patient's will, and we explain how to use on demand daily, what are the preferences, and they could actually switch from one to the other regimen, every time we see these people. So I would say right now in France overall, among MSM, 50% use TDF-FTC on demand, 50% daily. And the cohort data we have an ongoing study with the ENRS. The study was started in 2017. It's still ongoing. And after 3 years, the incidence of HIV in both arms is very low. And we don't see any difference between the two regimens in terms of HIV incidence. So it seems like, they are equally potent to prevent HIV infection. And the rate of HIV infection in this cohort is very low. We see a few breakthrough infection only in people actually who were non-adherent to the prescribed regimen.
Yeah, thanks, Jean-Michel. And I think it's really on the strength of your Prevenir data that I think the panel in general has become so increasingly comfortable with the on-demand dosing experience and your incredibly low incidence rates in that population, that it's sort of elevated to that sort of high level recommendation on parallel with daily oral TDF-FTC. Of course, we don't in the U.S. have FDA approvals for use in that way, and the CDC has not endorsed it, and we're one of the few groups that has endorsed it in the U.S. Of course, the WHO has as well. And I'm wondering, Susan, in San Francisco, you guys and New York have been sort of fairly unique jurisdictions in recommending it. What are you seeing about uptake in San Francisco of on-demand use?
It seems to be increasing all the time. Now, not all providers are yet comfortable prescribing it. Those providers that are comfortable prescribing it and who offer it, it's still probably, I'm guessing, around a third who are taking it up. But I would say that with COVID in particular, more and more people seem to be switching to 2-on-1 PrEP. Because their sexual encounters are less frequent, and it just makes for an easier regimen to use when you're not having frequent sexual practices. So, but it's definitely taking off here in a way that I think it's not taken off necessarily in the rest of the country yet.
Yeah, Susan, that's so interesting. I'd love to hear from other panelists who are in other regions if it is taking off in their regions at all. The thing that in LA that we hear the most, people who want to sort of think about using TDF-FTC in that way, is they're having a hard time finding, patient-friendly instructions about how you do it, how you operationalize it. And, our clinic has worked on that, modeled on something you guys provided, but it seems to be sort of a need for patients who are interested in using it in that way. I'm wondering if you found that, or anyone else on the panel. Have you heard that from patients that they're interested but don't quite know how to do it?
We also have been giving out directions, and actually at one of the clinics they have particular reminders that are used. We're in the process of developing an app that can help people use 2-on-1 PrEP more effectively, because you do have to remember, when did you take your last dose? When are you supposed to take your next dose? It's not a completely clear and straightforward regimen, so it does require a little bit of education. And we do have some materials that we patterned off of what Jean-Michel has done in Paris. So I think everybody's been borrowing from everybody else.
How about others on the panel? Do you get requests for 2-on-1 PrEP?
Yeah, very much so. And you get requests, and even if you don't get requests, the patients frequently, the participant, the person said, well, I'm going to do this, right? My friend is doing it. I just want to know exactly how to do it. But there's interest because they heard about it and others are doing it. So I do think that, it's unfortunate that CDC and others have not approved it and recommended, because it's already a practice out there and it's already happening. And I think having clear guidance is really important.
Yeah, this is Raj. Like Dr. Buchbinder, in the era of COVID, I've been actually recommending it even more commonly than I did in the past, because people, for the reasons she said, are, having less frequent sex, and it doesn't make that much sense to me to take it 2-3 months at a time daily if the sexual encounters are, every couple of weeks. And so I think that more of my patients are now taking 2-on-1 than they were a year or two ago. It is as I think people keep saying they'll really studied only in MSM, or at least should not be used in cisgender women. Let's put it that way.
Yeah, thanks, Raj. I think it's really interesting, the sort of scale up of interest during the COVID era. And, there's this big debate about whether or not we're seeing more risk or less risk in the COVID era. Are people sort of sequestering and not having sexual activity, or are people sheltering in place together and there actually is more cohorted sexual activity? And I think there's some evidence for both, and I think it's very provocative. I think the biggest challenge, of course, is being able to plan for that sexual activity as a requisite for being able to leverage the power of the 2-1-1 dosing. There is a question in the chat that people are asking, how do you sort of prescribe it? And I'd love to hear what others do. Our guidance and what I have done is I prescribe it and monitor it in the same way I would as if it were being taken daily, because I think the power of it is depending on the frequency of sexual activity. You can sort of either have more limited use around a single planned episode or more chronic use, which sort of devolves into daily use if the sexual activity continues. And so you have to assume that somebody could need a full 3-month supply, at that quarterly monitoring interval. Are others doing things that are different?
Well, that's exactly what we do. I mean, we see patients at the same frequency, whether we give them daily or on-demand PrEP. We want to continue to monitor HIV and STIs. And actually, during COVID, we've seen quite a significant drop in STIs rate among people with HIV. We've seen also a few HIV infections, but mostly among people not on PrEP still. So, not everyone, among the MSM community in Paris is using PrEP or knows about PrEP. So we still need to, advertise PrEP more than we do today. And it's a shame to see these young or not so young MSM, getting HIV and not knowing about PrEP.
Yeah, I think, no, go ahead, Raj, sorry.
I was just going to ask Jean-Michel, on the era of lockdown, are you having any success of having patient-collected sampling for chlamydia, gonorrhea, et cetera? We have not had too much success in Boston, but in the United States, regional variations, and maybe the folks in California can comment on patient-collected specimens, but what about in Paris?
Well, we did that within a study, not in routine care. So within a study, worked quite well. Then there's a cost of, sending the samples, but the acceptability was very high in the study we conducted. So clearly, then you have to set up the organization to do that. But it seems like quite attractive for people.
Yes, similar here in Atlanta, we've done under Aaron Siegler's leadership a PrEP at home study, and it works well with this, sort of boxes that he has developed that have all the tools and a video and everything, what to do to collect your samples and to do your HIV, even to do your blood, that you can submit your blood spot for the HIV testing and submitting everything by mail, and then you can mail your drugs. So it opens the opportunity to do sort of tele PrEP and the testing. But again, I go back to what I said before. We're simply not being able to do STD testing right now. So it really is irrelevant of how you collect it, because we're not getting STD testing on our patients because of COVID. I mean, there's just not swabs and there's not, reagents. So everything's being used for COVID, which means we're not doing STD testing. We're being told to go back to syndromic approach.
So, Carlos, that's really interesting, and I wonder if there's also some regional variation on that availability, because, we had a brief period of time where that was certainly true in Los Angeles, but it's not currently. So I wonder if there are regional differences in availability. It certainly would be frustrating to need to be forced to go back to purely syndromic management, since we know so many of these STIs are asymptomatic.
Right.
And the sort of one of the powers of a PrEP program is the ability to interrupt that cycle early with the asymptomatic testing and diagnosis. There's a question in the chat about whether some of the commercial labs have increased their willingness to do 3-site testing to allow more remote video visit management of PrEP. And I have heard of some of the commercial labs increasing their willingness to do it now that there is an FDA cleared extragenital assay that's approved in the US, but I do think there's variability. Have others had success with any of the commercial labs being willing to do pharyngeal and rectal testing now that there is an FDA cleared assay? Silence.
We have not had any problems with that. So both Quest and LabCorp have done that. Our biggest problem, as Carlos said, is not being able to get the swabs to do any testing at all. And I would just mention that there may be some regional variation, but I've actually done some informal chatting with people across the country who are HIV folks who actually are seeing the same thing. So I do think we're being told it is a national shortage in the major commercial labs. So I do think this is a major concern. And, you know, by the way, if this is something that is driven by COVID, it would be a great way to use the Defense Production Act to actually increase the number of swabs that we have, not just for COVID, but that would have a ripple effect on lots of things like STI testing. But far from me to recommend anything regarding policy, but
no, Melanie, please continue to advocate for policy. I think that's critical, and I think that's a really great point. So thanks for bringing it up.
Maybe while Dr. Thompson has the microphone for a minute, if you don't mind, she just issued some guidelines from HIV-MA on primary care of people with HIV. Just for a moment, do you still endorse urine analyses in people on TAF? Melanie, one of the questions in the chat was, should people keep getting UAs if they're getting treated with HIV with TAF? What do the primary care guidelines say?
We do. I don't think there is a lot of evidence, basically, to rule one way or another on that. I know that a lot of people have stopped doing that in people who are on TAF and who have apparently stable renal function. You know, unfortunately, in many populations, there are lots of reasons to monitor urine because of comorbidities, hypertension, diabetes, and so on. And, you know, we have so many patients in the South who have comorbidities and are taking PrEP that, you know, it gets a little confusing. But we have not said that you should stop doing UAs in patients on TAF. And thanks for plugging the guidelines, by the way. I'll plug a little bit more to say the HIV primary care guidelines we hope will be published very, very, very soon, like maybe even sometime next week, maybe.
So keep an eye out on Melanie's Twitter. If you don't follow her on Twitter, please do. And she'll put her Twitter in the chat. But I think that's a very nice segue to probably the second most controversial or discussed, I shouldn't say controversial, issue in the guidelines, which was how to position TAF-FTC as a PrEP agent, at least for non-vaginal exposures. I think everyone's aware that the US FDA did grant regulatory approvals to daily oral TAF-FTC for non-vaginal exposures as a PrEP agent last October, and it's getting a fair amount of attention in sort of the marketing airwaves, and a lot of patients are asking about it because of a perception that's out there that certainly in the treatment arena, there are data to support that there are clinically meaningful safety advantages in a renal and bone context to using TAF over TDF-FTC, and do those safety advantages similarly apply in the prevention context to people who are not living with HIV? And how do we triage the thought process of the ultra-sensitive laboratory measurements of a salutary creatinine clearance profile and DEXA measurements of a salutary bone profile with LDL disadvantages and weight increases as we think about these agents? And of course, the fact that, as Jean-Michel was alluding to, generic TDF-FTC now available in the United States. And so how do we think about that? And, the panel's recommendation came down on recommending TDF-FTC as a first-line agent, with TAF-FTC as an agent that may be appropriate in certain high-risk settings with people with pre-existing renal disease, certainly with creatinine clearances between 30 and 60, or at risk, or pre-existing osteopenia or osteoporosis. But I'm wondering, how are people on the panel in clinical practice making those decisions and having those conversations with patients as they ask about it?
This is Davey. Thanks. I have this conversation more than I thought I was ever going to have. But I noticed a lot of patients are totally happy with TDF, but some that are very concerned about the bone issue want to have lots of questions about it. And usually they walk away not necessarily demanding TAF. But I have noticed that I use it. I have a few patients who have some bone issues and some creatinine clearances that started to bump up, and they all had other pre-existing conditions, and I did switch them over to TAF-based prep.
What are others doing? And I'll just, while people are thinking about that, I find myself gravitating to Julia Marcus's infographic. If anyone hasn't seen it, Google Julia Marcus TAF-FTC infographic. It's brilliant. And I have it printed out and laminated, and I go over it with patients and what we know to date about the various considerations of both agents. And then I sort of say to people, what would you like to do after that conversation? And I'll share that after having that kind of detailed conversation, it has been a case report level situation where someone has said, yeah, I still want TAF-FTC. What are others' experience?
I think most people are willing. We say that we're actually recommending TDF-FTC for first-line prep unless there's a reason to that somebody needs to take TAF. And so, in general, people, I think Julia Marcus's infographic is really helpful in laying things out and in describing, for instance, the bone mineral density, that we didn't see any clinical difference in bone disease in people who were taking PrEP with TDF-FTC. And similarly with the renal diseases, if somebody doesn't have pre-existing conditions that might predispose them to having renal disease, I think people in general have been, there are exceptions, but people in general are willing to take TDF-FTC, especially since that we say that's our recommendation, but we do have a conversation about it.
Yeah, and one of the things that actually came up in the Q&A that the audience sent in was about the safety, and is there a difference in terms of bone mineral density? And the answer is yes, there's a little bit of difference. But the big issue here is that, first off, DEXA scans weren't really developed for people who are 25 years old. I mean, the standards and normality of it is for older folks. And so when you see a little bit of a change in bone mineral density, which is observed, the question is, what is its clinical meaning? And I think in the opinion of the panel as we sat around, the answer to that question was not much. I think you framed it really well, Rafi, when you said it's really all about relative assessment of an individual's risk for especially renal issues. But if there's not much risk there, then the TDF-FTC works just fine. And I'm not finding, at least in our practices here in Alabama, that that's been a big push, but it may be geographically different.
Yeah, there's a great question here in the Q&A about what about teens and young adults who sort of are traditionally challenged by adherence, still accruing bone mineral density, and also maybe challenged by the large pill size. And I think those are really important considerations and contribute to the individualization of the conversation with someone, right? There's some pharmacokinetic data that suggests that based on intracellular levels, perhaps we're going to find that TAF FTC is more forgiving to non-adherence. I don't think we really have the answer to that question yet. So I'm loath to jump to that as a reason. I do think there's a small subset of people who pill size is an issue. And that may be something that tips in the balance of favoring using TAF FTC. And I think it's an important point to remember that while we do say that the DEXA changes that we see in adults revert to baseline 6 months off TDF FTC prep, the one population in whom that wasn't true was young adults and adolescents. So they don't return to baseline. So this question is still a lingering one about bone effects and people accruing mass. But again, no data about different clinical outcomes to drive us. So it's a little bit of a challenge.
So Raphael, we have about 3 or 4 minutes left, and I think a good segue from that question you just asked from the audience about what might be an option when adherence. What about long-acting injectables when they become available?
What about them, Mike Saag? So, I think a lot of people were surprised, happy, raised an eyebrow when they saw that we recommended long-acting injectable cabotegravir for MSM and trans women, should it achieve regulatory approvals and become available. And, full disclaimer, I was heavily involved in that study. So perhaps it would be most appropriate for me to sort of turn it over to Susan or Jean-Michel or Mike, if you want to comment about some of the factors that went into our prioritizing that as something we really wanted to highlight in these guidelines. And then I'm happy to chime in from a study perspective, but perhaps I should, for equity and lack of bias, turn it over to others to lead that conversation.
Well, I think we've learned with the treatment of HIV that patients, when they tested long-acting agents, are really very happy with that. So I think, once it's going to be available and people will test it, they will adopt it, at least some of them. So I think it's great to have a new option with, it's a single drug, single agent. That's also nice. The safety looks great. And so, I think the experience we have again with the treatment of HIV is quite good. So people are, really asking for it. So let's see what happens with cabotegravir for PrEP, but I'm quite optimistic.
Yeah, I think just to share with the audience and kind of go inside baseball here of how this was debated amongst the panelists is that we looked at the evidence, and I think everybody was impressed, as you just heard. The problem was the drug wasn't released yet, but we knew that these guidelines would not be updated for another 2 years or so. So we decided to jump ahead of it a little bit, including discussions about some of the toxicity issues. I think the one thing that is worth mentioning, because we really only do have about 1 minute, 24 seconds left, is the issue of resistance potentially. If there's given and then 3 months later nothing else is done. So maybe the experts on the panel can talk about that as we wrap this section up.
If you could say that and also say what you think about women where the study is ongoing, maybe those are the two last things for you to finish up with. Maybe Raphael's fine.
Yeah, thanks, Raj and Mike. So, I think everyone is aware that there is a sister study to HPTN 083 that is being done in cisgender women in sub-Saharan Africa that was about a year later getting into the field than was 083. So it's about a year behind in results. And remember, 083 resulted in May of this year. The 084 study is undergoing its next review by Unblinded Data Safety Monitoring Board in a couple of weeks. But it is ongoing, and we don't know what's going to happen. There may be a result. It may need to continue, but it's being studied. So we're optimistic and hopeful that a similar result will be seen for cisgender women, but we don't know yet. And the resistance question looms large. We don't yet have all the data, but certainly if acquiring HIV despite or in the context of cabotegravir use does lead to integrase class resistance. That's going to be important and have implications for first-line WHO treatment recommendations and could have important consequences. So I think that's an unanswered but really important question that in order to appropriately balance and understand the risks and benefits of each modality, we really need before we can fully evaluate it. And with that, Mike, I think I'll send it back over to you. We did not get to a ton of the questions in the chat, and we'll try and answer them for people, even though we weren't able to do so live. But thank you so much, everyone, for putting in those questions. They're all really good and important questions.
Yeah, if y'all want to type in on those as we go to into break, then we can clear them out. That'd be great. Thank you. So thanks, everyone. I think that was a wonderful discussion, and I think it helps a lot. I think just to add to that last comment that once somebody gets an injection with cabotegravir in the PK, there's a nice peak, and then there's a very prolonged what's called tail, or as the drug is eliminated. And if that tail extends for 2 or 3 months and somebody gets exposed, theoretically, there could be the breeding of resistance, and that's the concern. So we're going to take another 20-minute break. We'll be coming back at 10 minutes until the hour, 15 minutes after the previous hour. And Dr. Gandhi will lead us in a discussion of COVID, or an overview of it, a brief discussion. And then Dr. Hoy will be joining us from Australia to lead a discussion on something that is brand new in the guidelines this go-round, is about how to manage patients as they age with HIV. So we'll take our break and be back in 20 minutes.